Hi, everyone. This is Lucas Voss with Becker's Healthcare. So great to have you. Thanks so much for joining us for today's webinar, How Ascension Living is Balancing Per Diem Flexibility with Long-Term Workforce Stability. Before we begin, just a couple of few quick housekeeping instructions here for you all. We will begin today's webinar with this discussion, and we'll have time at the end of the hour for a question and answer session. Make sure you write down your questions. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. And today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access that same recording. If at any time you have any issues with audio or visuals, just try refreshing your browser, and you can also submit any technical questions into that Q&A box. We're certainly here to help. And with that, I'm so very excited to introduce our two speakers for today's discussion. Erin Shadbolt, she's the Chief Executive Officer of Ascension Living, where she leads a mission-driven organization dedicated to delivering holistic, person-centered senior care across 30 communities in 9 states. With a background as a nurse and a 2025 Senior Housing News Changemaker, she's recognized for advancing technology-enabled workforce strategies, leveraging data, real-time staff feedback, and agile staffing models to elevate care quality and operational efficiency, including per diem utilization. Prior to joining Ascension Living, Erin held leadership roles at Mayo Clinic and Intermountain Healthcare, where she helped shape innovative care delivery and workforce transformation initiatives. And we're also very excited to be joined by Liz Cunningham. She's the Senior Vice President of Workforce Solutions at AMN Healthcare, leading client delivery and strategic support for healthcare organizations nationwide. With expertise in digital operations, product management, and IT, Liz drives innovation throughout AI, data-driven strategies, and high-performing teams to enhance efficiency and improve patient outcomes. Her leadership ensures AMA's technology solutions align with organizational growth and transform workforce management across the healthcare ecosystem. Again, it's so great to have you both here, Erin and Liz. And Liz, I want to kick it over to you for a fantastic discussion.
Thank you, Lucas. And Erin, thank you so much for agreeing to do this discussion with me. I think the audience is going to love some of your insights around the per diem space and the post-acute space and really what you've done to evolve healthcare. So let's just kick it right off with our first question. I'm curious from your perspective, what workforce trends you've been observing in your space, specifically around per diem and flexible labor models, and what has that looked like for you and for Ascension Living?
Yeah, thank you, Liz, and thank you so much to Beckers for having me here. I'm so excited to talk about all the work that we're doing around our workforce at Ascension Living. I think for us, what we are really seeing, and what I've seen in the industry, particularly, I think coming out of COVID, is there's an expectation for some flexibility that unfortunately doesn't always align really to what our resident needs are. And so we're thinking a lot about how do we create a workforce that it's easy for them to use benefits like PTO, that we have some options for different shift schedules, different times, different days. And really having a strong per diem staffing pool is an important tactic to be able to do that. And having a partner in that you know is going to deliver the quality of care that is aligned to your own organization's expectations is really important. For us, we're really also thinking about there's a lot of stuff that takes our clinicians away from the bedside. And it's things we want them to do. They need to do education. They need to use their PTO. They need to complete training. We want them to go to skills fairs. So we also are advancing kind of our data infrastructure to really predict that time that clinicians might be away from the bed and think about how do we best cover that time through a combination of per diem agency, our own staffing, and then just thinking about kind of some of our physical layout and digital access. An example of kind of how we're thinking about flexing labor to support resident needs is we track the day and time of day of our falls, and we have used that to adjust staffing models. So in some of our communities, we've been able to narrow down, okay, 25% of our falls with major injury happen in this period of time right around dinner. So we know we need extra staff during that time. and we might not need that same staff from midnight to 4 a.m. So being smarter about how we're really matching our staff schedules to resident needs and then creating flexibility for our associates is really something that we're seeing is necessary if you want to be differentiated amongst associates that are looking for work.
Erin, there's so many nuggets in there I want to unpack with you, but I would love for you to maybe take a step into how you've landed on your current solution. So if we're thinking about, you have a pretty big, a robust per diem model, which makes sense, right? If you're trying to allow your clinicians to have continuing education to take time away from the bedside. How did you land where you are at in your strategy? And have you tried anything before that you're like, it didn't really work for us? What does that look like today?
Yeah, so it's a really tricky balance as we're thinking about how do we really just manage this real complexity of the workforce and where they're at. One of the things that we're really thinking about is how do we create our own internal per diem pool? So we do offer some really nice pay rates, honestly, for our per diem staff. There's not benefits associated to that. We also have created a workforce strategy of a combination of some longer term contracts and some short-term per diem so that we can really kind of stabilize that day-to-day consistent staffing, but also cover those unexpected last-minute needs. And then we really are also, in the past year, especially, Liz, one of the things that's been so important to us is transforming the way that we take care of our per diem agency and really any agency, even if they are longer term, and how we onboard them, how we talk to them, how we include them as part of the team makes a big difference in sort of how they perform out on the floor for us and in their interactions with residents and our own associates. So that's been a really important part of sort of ensuring that the care of our per diem agency staff aligns with our mission. But we also have found that then creates an environment where, like many places, we're trying to move out of agency. It creates an environment where when our agency staff see those shifts disappear, they want to come work for us and we get reach outs, and it creates this pipeline for us that has been really nice. And it's a really nice partnership with our agencies.
Yeah, that makes a lot of sense. And, what's interesting is my next question to you is actually going to be about the culture with your perm staff and the cohesion with per diem. But I love your perspective of that you actually were focusing on the environment to make the agency workers feel comfortable too. It sounds like that's an important balance. And, did you have to do anything different though with your perm staff, bringing in agency to maintain that cohesion, that quality of care, when it maybe feels a little bit more ad hoc to them with per diem folks coming in?
Yeah, it really is. Staffing is complex. I mean, it's really complex. I would say scheduling staff is probably at the bottom of the list of things that I find fun at work. So grateful for excellent schedulers that do that work and do it well and often just really love it. But one thing for us, like I said, we're working on this consistent orientation for our agency associates, but we also have really transformed the way that we orient our own associates. We also have added a nurse educator role, and that nurse educator role supports all of the associates that are in the building at any time. So we have sort of addressed this with our associates by committing to, we are going to make sure that if you need staff for safe resident care for a shift to go well, we are going to get you staff. And we also are going to train them to our expectations and hold them accountable. And it has driven just a really high quality of agency staff. And I think at least a little bit of an understanding on our own staff side of, okay, they're working on it. The agency staff that come and they do a good job and they are actually helpful. And also there are less over time, which makes our own staff feel good. And there also is a piece of rewarding our associates that are helping us convert our agency staff into our own associates. So bonusing them, and really just making that part of our culture. Our culture is if you're here and you're working in the building, we want you here with us on our team whenever possible.
Right. So you're looking at them as a future permanent employee, right? And teaching them as
Yes.
yeah, that makes sense. And I hadn't heard the kind of rewarding your existing staff to say, hey, you make a good environment for these people. It's almost like a referral, right? It's kind of what it sounds like.
Yes. Yeah. And
Yeah.
Liz, it's really interesting actually. I just was at a hiring event this week at one of my communities, and it was really incredible the number of applicants into that work in our buildings as per diem agency. Like it's not a dream that can happen. That is now our lived reality, where as we post positions, as we have hiring fairs, we find that our per diem agency staff are our top candidates. And we are seeing a little bit of a shift in, I think, the industry where we're starting to see more staff that want to be part of a team if they
Right.
find one that's really good.
Well, and that's a testament to the environment, right? Not a lot of folks can say that about, the cohesion with their per diem and their perm. So congratulations there on that
Thank
success.
you.
As you think about, and I know you say the line like, hey, we're all trying to get rid of agency. We understand, right? There's this kind of necessary balance that happens over time. But what are some of the tactics you're trying to do to prevent the over reliance on those PRN or per diem staff while also trying to meet, the needs and the various spikes in census or demand that you have?
Yeah. So we're using a few different tactics for that. One is we've identified a core staffing model at each building that has to be filled with core scheduled staff. We are not allowed to use agency for that. That is your staff. You need to have staff for that. And we do have communities that we have gaps in our staffing. And so we're using per diems to actually fill a spot on the schedule, not just for call offs or for PTO. And that we've really said, we just can't do that. We have to hire up. We have to focus on retention, getting people in. And where we're seeing a lot of per diem consistent agency use like that, we really are trying to implement some longer term contracts just to create some consistency. And that does help with some of that culture between our associates and our contract if they start to kind of build a relationship. We've also identified a number of uncovered additional shifts. So, we have shifts that are just open because we do encourage and allow our associates to take PTO. And then we have this time that, like I said, training, education, and that helps us identify, okay, this is an appropriate number of per diem hours for this community based on this amount of time that we know is just a gap in their schedule. We also see that just local workforce availability really impacts that. We have fairly stable staffing at a lot of our communities, but then we have other communities where we have this really cyclical staffing challenge. So college towns are a good example. We have towns that are located near military bases. We see a lot of kind of turnover there. And so, we also are really trying to apply a balanced approach to covering the urgent needs. How do we pre-plan for likely open shifts? How do we incentivize our own staff to pick up those shifts? How do we think about on-call positions? We also have a really interesting tactic here that I think is pretty unique. It's called our short-term option. And Liz, that's almost like our own internal agency long-term contract. It's 90 to 180 days that our associates can sign up for. And it's like a long-term agency contract. You're not a real associate. The pay is a little bit different, more like an agency, but we see good success again of converting those short-term option folks, both CNAs and nurses, into full-time permanent positions for us. And then we also, of course, are making sure that our leadership staffing models are designed in a way that allows our clinical staff to be able to support covering some of those shifts if needed, so that our clinical leaders are have some flexibility to be on the floor if we need that to avoid additional and excessive per diem agency staffing.
God, it makes sense. So that sounds like, a lot of that too is aligned with your goals around retention and reducing burnout. And I'm curious, those kind of short-term positions you're talking about, is that also a flexible option for your perm workforce? Like if you have someone is feeling burnt out, they can go to a short-term kind of assignment, try something else, or is it more of that kind of front door entrance?
Gosh, Liz, I don't know that we've really thought of it as a way to like let our current associates experience like a different community, but that's a great idea.
Yeah,
I'm gonna bring that back to my team. That's a good
let's
one.
ideate a bit here.
Yeah, all right. We're gonna solve all the problems on this webinar. Perfect.
Well, Erin, I would love to pivot real quick towards kind of the space that you're in versus maybe some more of the acute health system. So thinking about post acute and the differences in the types of staffing models that you encounter that you've implemented. I know you've been across a multitude of settings throughout your career. So what is different about the post acute space? What is more challenging? I mean, I even heard you say something earlier around, as we think about schedules and you go to acute, you're looking at predictive census, right? And you're looking at times that your residents could be falling, right? Like even that's like a different metric. So how do you see these flexible models being different in the post-acute space versus the acute space?
I well, just one comment, and this is very much my opinion. I don't think that we've found like the next incredible thing for scheduling and senior living. I think it's coming. I mean, man, we have such great minds in the industry and such great vendor partners on the business side. It's coming right now for us. We're moving towards a preferred scheduling model. We're doing that by aligning technology, right? So you can't have kind of these advanced flexible scheduling if you're doing it on a piece of paper. I mean, you probably can, but your scheduler is probably not going to be super easy to retain. So having a scheduling platform that allows for you to open shifts, that allows for your clinicians to pick those shifts up easily, they really need to be able to do that via cell phone in some way. That has really been helpful. And it also helps our associates start to see, in some ways, the complexity of the staffing. When they go in, they can really see like what's open and what isn't. They get a little bit of a better sense of just what is happening in their own community where they're working. As we're implementing that technology, we are really seeing that that preferred scheduling is working well for our associates. We are seeing them just appreciate that flexibility. And for me, a lot of my associates work another job too. So they're often just working through some really complex timing and scheduling needs. And like I mentioned, we do have these short-term option or kind of like a micro contract roles. That has been really helpful for transitioning high quality employees into these full-time roles. And we do a lot of set schedules, which is really important for people working another job. You know when and where you're coming to work every week. It doesn't change unless we've had a conversation with you. And then we allow those set schedule folks, of course, if you want to pick up extra shifts, you certainly can. If you want to trade, you can. We have tried float pools, and I have experience running a float pool in acute care as well. And it is, I think, trickier in senior living than it was in acute care. And I think the reason why that is, a hospital tends to have a culture, and there might be some variations on each unit, but you sort of know, like, this is how we do things in this hospital. This is how it feels. This is how we work together. This is how we staff. This is how we document all of that. And in senior living, I find that my communities just vary a lot more than units in a hospital do in terms of the culture, in terms of how people work together, how they communicate. We see just little process changes around some of that stuff, which is totally appropriate. It doesn't impact our outcomes in a different way, but we have found that it does make something like a float pool a little bit harder. You have to screen for somebody that is going to be a little bit more open to really different cultures and maybe needing to do something different one place than they usually do at the other place, which can be a little bit stressful for people. And of course, that's not around like clinical care processes, but just, who do you give shift report to and when and how? And those things do like weigh on staff sometimes.
Right, the environment. Well, and I'd have to imagine too, and I'd love your thoughts on this. In the post-acute space, or in senior living, because you have all these different facilities and cultures associated, has it been challenging trying to get more systemization
Oh
across
my
all of
gosh.
them? Like, what does that look like to you versus, the health systems, and what lessons have you learned that you could be, giving to the audience around creating that sameness, right, across all the facilities?
Yeah, so we have been trying to move towards this kind of systemization or sameness for a while. And, you know, Liz, it's hard. People are very, and for my ministry, Ascension Living is made up kind of all of these of pieces of all of these smaller historical Catholic ministries. So they have a
Mm-hmm.
very deep culture and history, and people are very connected to the founding. Often they've been founded by, original religious orders. So lots of meaning behind the history of that, and a lot of reason why driving sameness quickly is not probably the right thing to do for my organization. But what I've really said is, okay, we're going to focus on what outcomes are not negotiable. You know, we have to have good quality. We have to manage our HPRDs. Like there are just outcomes that we have to get to, and there has to be sameness there. And where we know that certain things get to those outcomes 100% of the time or 95% of the time, then it's not optional to follow these processes. And that's really how I think about it. If I know a process is going to drive the outcome I want, then the process is not optional. If there are a lot of different ways to get to this outcome, then we can allow some variety in how we get there.
That makes sense. Yeah. If the end destination is the same, their directions could be slightly different to get there if they want to,
Yeah,
right?
and
Yeah.
and in senior living, I mean, I think it's like this for a ton of us. Every single community has a different physical layout, a
Right.
slightly different staffing model. Like it's just all just a little bit different
Yeah.
enough
Different
that
patient populations. Yeah.
it gets real hard to drive that sameness.
Yeah.
So yeah.
That makes sense. That makes sense. I heard you, Erin, mention shorter schedules, kind of picking up shifts, things like that. A lot of when I'm talking to my clients, we talk a lot about gig economies and marketplace and what some of those kind of newer innovations in self-scheduling and staffing look like. What does that look like to you? Are you trying anything new there? Do you want to try new things in that space? What do you think makes sense for you for the senior living space?
Yeah, I would love to try some new things in that space, Liz. We're in the middle of moving to the technology platform. I think that is going to enable that. And then we have another technology move later this calendar year that will probably be sort of the final technology enablement for us. But one of the things that I've thought a lot about is part of my work at Mayo Clinic was I helped them with their home hospital model. And the home hospital model is really interesting because it really kind of says, we provide too much care in the hospital. And so instead, we'll put someone in their home and we're going to provide the exact right amount of care for them in that moment. And that concept, I think, is really applicable in our world if we can get the technology to support it. An example of this is, we know it's really important in the skilled nursing world to have a really strong restorative program. Well, do you have to have all of your restorative team scheduled for full shifts, or could you actually have a couple of 2, 4, 6 hour shifts? Maybe they have a portfolio of residents that they're working with and they're kind of flexing their schedule. We are always going to have shift work that just has to be done with a certain number of bodies. But there is a lot of other work that is actually really not shift work that we could create some real flexibility to get some real high quality associates into our buildings. And I think about two things like, the wound care nurse. Is that somebody that they come when it is convenient for them, and that gets us the best quality candidate possible. So there's a lot of opportunity if you have the technology to sort of track that all the needs are being met with these, incremental little gig shifts that people are picking up.
Got it. Got it. That makes sense. So it's kind of like, tell me if I'm understanding correctly. So you have when people are talking about shorter shifts, right? Like a 4 versus an 8, but you're almost talking about it's a combination of that, but also like unit based.
Mm-hmm.
Like a unit's probably the wrong word, but like, visits or things like that versus like a whole shift.
Yes. Yeah. And I think about that. That's somewhat similar to the way that it works in, some of our other post-acute settings like home health and hospice,
Right,
right? When
right.
I was a hospice nurse, I had 11 patients. I just had them. I could see them sort of when the patient and I decided that it worked. And we're in a different setting than that, particularly in skilled nursing. But I also think, like, well, we're not in that different of a setting when we look at some of the housing flexibility that we have and really meeting individual resident needs with some different staffing shifts, I think is really feasible. But I also want to say, Liz, on the other hand, I can't tell you how many times I interview people that are like, I only want to do doubles. I do doubles. I want to work 16 hours. Don't schedule me for 4 or 6 or 8, 16. So I think also just being flexible with kind of a variety is really important.
Yeah, that makes sense. I want to pivot the conversation a little bit into talking about maybe tools and different things that you're using to actually manage the various labor pools or even analytics, things like that. I have an IT background, so I have to ask a couple technical questions. But, I'm hearing about all these creative models, flexible models that you're running across your various facilities. How are you actually facilitating all of this? Like, how are you bringing all of this together? Like, what types of tools do I've heard you talk about some more advanced scheduling you're looking at, but what types of tools um, you know do fellow peers need to look at to be able to truly kind of manage this spectrum?
Yeah, so I think, Liz, there's a couple different ways that you need to think about this data as you're trying to decide future state of staffing models or hiring decisions. We're watching leading indicators every single day, call offs, hires, exits. I want to know every single day, did we add more associates today than yesterday? Because we are using a lot of agencies. So we know that we need to do that right now. We also, though, are watching lagging indicators too, of course. So associate experience surveys, we do those a couple times a year actually, and try to respond to those. 90-day turnover, and then just general, how many hours of agency are we using? And as we look at those metrics, we do that on a community by community basis. And our community leaders really kind of own that with the support of their regional team in tracking those leading indicators, watching their lagging indicators, and sort of tying it all together. We do have kind of a unique position, I think, in our organization, which is a manager of scheduling. And scheduling, I would argue scheduling is one of the hardest jobs in our communities and probably in healthcare. It is very difficult to schedule clinicians to meet patient or resident needs. We have a scheduling manager that sits in my corporate office, and she meets weekly with every single scheduler one on one. She reviews kind of their core staffing. She is the one that's helping them transition into the electronic scheduling system, training them on it, running reports with them, and training them on their data. So there's also, as the CEO or maybe the COO, if you're out there listening to this, you really, I think, have to think about what resources does your team need to be successful in applying potential new models. And it's really complex, especially across different levels of care, different minimum staffing in different states, different budgeted PRDs, and having that person that is sort of a smiling, friendly face behind, like, don't use agency, right, has been really helpful. And she provides some early insight that maybe things are about to go off the rails somewhere because we are seeing more agency creep up, more call offs. So that role has been really important. So technology is really that is the baseline of what gets us where we need to go, but having your people able to use your technology is really important. And for us, we needed a person to help support that because we're in a transition.
Agreed. Well, and I'm assuming that person too helps with that systemization we were talking about, right? Or we can call operationalization, right? Across all the facilities and that adoption
Yes.
journey in the technology, which I know you guys have been working through.
Yeah. Yep. That's right.
Absolutely. Okay, so as we think about, looking forward, you mentioned slightly, that you felt like, hey, senior living post-acute is probably a little bit behind in terms of new innovations in technology scheduling. But what would one technology innovation be that you would be looking for in your space to strengthen your workforce and that broader workforce management?
I love that question. And I am a nurse by background, so I think I tend to look at this from like the bedside nursing perspective more than the operator. I cannot wait for narrated documentation to come to senior lives. We've seen that in the acute and the ambulatory
Right.
space for a few years. I have a dear friend of mine that is building out this like really incredible narrated AI supported documentation. I just see some of the stuff that people are out there building and developing. And unfortunately, so much of that tends to be acute and ambulatory
Yeah.
facing first, but they've had it for a few years. So you and I
Right.
both know that means it's coming to us in senior living, right? So, it's starting to get affordable. We're starting to see that being built into our EHRs. And for me as a nurse, I think it's so important to sort of talk to your residents, anyways, about your care, what you're seeing, what you're doing, why you're doing it. And of course, we know that we have a lot of memory support in all of our settings. So, we also have this issue where there's some cognitive deficits for many of our residents. And so a stranger is sort of touching you all over, really speaking about what is happening and what you're doing and why is really helpful. And narrated documentation allows the nurse to do that in a way that um, is really natural to the patient. It's a conversation, but it captures this really robust, nice assessment. And we see a lot of challenges in getting consistent documentation throughout the EHR. We do narration and then we do check boxes and they don't match. It makes everybody crazy. I think this ability to start to really document based on the ambient information of what is happening around that resident is going to change our lives for the better, both associates and residents.
Absolutely.
So I'm excited for that. I hope it's coming soon.
Well, that's what my first question was going to be like. Why hasn't it come to you all yet? Because I know because you're like, would you be including kind of AI scribe as part of that like narration piece?
I I think ideally you would have some sort of AI in it. And actually, so like this is really my dream world. And this is some of again, like there's some of this out there. Ideally, as the nurse is narrating their assessment, Miss Jones, I just listened to your lungs. You sound like maybe you have just a little bit of wheezing. Has it been hard to breathe? Ideally you have in the background your AI assistant that is listening, documenting your assessment, and actually prompting best practice. So if I hear wheezes in someone when I'm listening to their lungs, there's a whole set of other questions that I should go down as part of my assessment. But maybe if I'm a nurse with 25 residents and I'm tired because I worked a double the day before, maybe I forget that. But I don't,
Right.
if AI is there helping prompt just basic next step of nursing assessment and a little bit of that critical thinking, because we know nursing is like this very high cognitive burden. Same for our CNAs. They're doing a lot of things all the time, lots of decisions being made quickly. It's easy to miss things. So this narrated documentation, I think, could really sort of move the needle on a lot of things. Now, why is it not in our setting? I think there's a couple of reasons. One is just expense. So, can you afford it? And can you make money selling it to the people you're selling it
Right.
to?
Right.
So, one of the reasons why we see vendors sometimes come a little bit late to us, I think. The other piece, though, is, the regulation, I think, creates some challenges for us. There's privacy concerns once you start to do narrated documentation and you're kind of capturing all of that audio. Um, you know, what should you store of that? Where do you store it? How do you make sure that there's sort of integrity in the EHR? So there's some, I think, additional stuff that I would guess some of the people out there listening to this are even starting to work through. And if so, thank you for blazing that trail for us. But I think it's coming and it is going to be pretty great for our associates and our residents.
Yeah, agreed. Well, and I think it's so, from looking at my own kind of data nerd perspective, like in your space, you have such an interesting case where you have long-term residents, where you are collecting ongoing data that you can, use it to make more intelligent decision makings versus at some acute care centers where you're seeing someone for a couple hours, right? So
Yes.
there's a wealth of data there that is going to be important to unlock and help your staff for sure.
Yeah.
Love it. Well, let's talk about, your broader strategy in 2026. So, I feel like you've made just great strides in innovation and obviously with the awards that you've received and things you've been able to do with Ascension Living. But what are you focusing on in 2026? What's the road ahead, or even in the next, 2 to 3 years? What does the road ahead look like for you with some of these workforce strategies?
Yeah, I think Liz, for me, we are spending a lot of time at Ascension Living, like I think many in the industry are, thinking about how do we really create something that is going to serve the middle market differently, and I think for many of us, we consider ourselves the middle market, and I would like to be able to access senior living if I need that once I'm older. And one of the things that I think is going to make that feasible is going to be very individualized care that residents potentially maybe they book some of those cares. Right now we do that through a lot of leveling or maybe just some per diem fees. But I could see a time where residents really are able to kind of book. I want my shower here. I want this person to come and put me to bed here. But I have family that's going to do it the other days of the week. And starting to really be able to a la carte choose the care that you need. I think that's going to be a real key to keeping what we provide affordable in the housing side. We also, then I think that matches well to the sort of gig economy work that we see, where now our associates can sort of pick up these requests from residents and they can say,
Mm-hmm.
yeah, I want to do Mary's shower 3 days a week. I love her. And I also want to put her to bed 1 day a week. There's again, there's a lot of complexity. I think there needs to be a lot of technology to manage that in a way that everybody gets taken care of. But it's the technology exists. It's sort of pulling it all together. I also think that the technology right now also is not always great at matching kind of staff to the actual staffing needs. So that's very manual right now, thinking through, okay, does this nurse have this skill set to serve this group of residents in this community? And really, technology should just be doing that in the background for us. And I know that there are some programs that do that, but that's one of the things that I see as a huge need for us moving forward. Um, I really do think we're going to see staffing, though, be driven more and more and more by resident needs and requests, less so in SNF. But even in the SNF side, I think a model like this could really create a lot of flexibility for our own associates, for our per diem agency in contributing to care needs. It allows us, if we were to have a flex up for some reason, we know exactly how many agency hours I need. So now instead of needing to pay agency rates for 8 hours, I know actually I only need this person for 2 hours because that's what they're booked for. So I think the technology is coming to be able to do that. We need the staff and the systems in place to do it. And we need to have thought through how the operational model is going to match that to create a feasible and sustainable financial performance.
Yeah, I love that, Erin. I think that makes sense for direction. And to your point, it screams you need to have that bench of staff there, right? You need to have the ability to look at all of the demand across the organization and just think about shifts differently. So thank you for that. I appreciate it. Why don't we turn it over now to the audience for some audience questions? So for anyone that has put a question in the Q&A, or if you want to add anything to the Q&A, please do so now. But Erin, I have a couple questions for you that have already come in if you're ready for them. Um,
Yeah.
I think a lot of folks are on the call probably thinking about, okay, Erin, it sounds like you've nailed this. You've got it down. You've figured out all these different pieces, but I'm maybe feeling a little bit overwhelmed by the amount of complexity across, all these different facilities or all these different states that I have. where should I begin to think about systemness or how to control kind of people, process, and technology in a system that's pretty disjointed?
Yeah. So for starters, my team would laugh so hard at that initial statement that we have it figured out. So I don't want anybody on this webinar thinking like, "Oh my gosh, I'm behind," because you're not behind. Like we are in the middle of this work right now. We're not done with it. Maybe we're halfway through, but I don't know. Like it's a journey. So I guess I would start there. It's a journey, and as we should with any journey, you really need to pick a direction that you want to go. And the best way to do that is to look at your data. What is going to make the biggest difference with the least amount of work for you? And some of that depends on what are you trying to do. For us, we really needed to drive quality. I mean, certainly finances are always on the radar for me in my role, but we knew that kind of our biggest gap to really drive census, which then drives performance, was quality. So that's actually where we leaned in. We leaned into how do we improve the quality of our current associates training and onboarding and the quality of our per diem and contract labor that we're using. And that's really paid off. That was a great place to start because I think it started to create kind of the culture of retention. And now we're kind of moving on to, okay, what is that core staffing model in every community? How many open positions to core do you have? What is your plan to fill that gap so that it's not just per diem agency, a new face, everything single shift every single day? And then what is your plan for how you're going to manage per diem agency moving forward? So we're kind of talking our leaders through that. We're providing them tools. And like I said, we're doing a lot of coaching right now. I mean, people aren't born knowing how to schedule and how to set up staffing models. So having someone in a role to really coach them is really important.
Okay, I love that. And I think there's a good follow-on question around, if there was one thing you could do in the next 60 to 90 days to improve stability and flexibility, double whammy question, what would your recommendation be?
Oh my gosh, stability and flexibility. So I think so what I'm actually planning to do in the next 60 to 90 days around that is there's a few things that we're
doing. A page out of your playbook.
Yeah, I'll just share what I'm working on this quarter. So one of the things is we have newly implemented nurse educators at each of our communities. So I know it's common in a lot of operators for them to have nurse educators or some sort of associate success coach. We haven't had that. And so we're really adding them back in to support kind of that clinical experience of our associates that are out there providing our clinical care, and helping just level set how we provide the care at the quality that we want. And that nurse educator becomes the person that is sort of the first face for our agency and that is helping set that culture. So the nurse educator role and ensuring consistent systemness with orientation, because orientation is a process intervention that we know gets us to a non-negotiable outcome. So talking about systemness, standard orientation is one of the things that's a non-negotiable for communities. They have to do it our way. They have to follow our slides. So not everybody loves it, but it's successful. So nursing educators, really getting them up and going. We also, Liz, just as a side note, we're in the middle of an EHR transition that will happen at the end of this quarter. That EHR transition will make the technology that we use at the bedside much more usable, much more user-friendly than it is right now. So it's not narrated documentation, but it's easier documentation. And even that, I expect to have a huge impact on our retention and our stabilization of our workforce. At the same time as we're doing that EHR transition, we are leveraging those nurse educators to really start to upskill our other staff. So I see that as critical this year to start to really invest in the upskilling of our staff. We've had so much turnover and so much agency for so long that it's been really hard to spend the time and energy and resources. And we're at a place now to really do that. So we're really focusing on retention and then sort of rigor around the scheduling process. So uh, that core staffing model that communities need to have, it sounds kind of silly and obvious to say this, but that should be at their budgeted PRD. And if it's not, that's a problem. And so that is one of the other things that we are looking at right now is the technology to help our leaders understand that their core staffing is or is not at their budgeted PRD. And then for us, as we are bringing on these longer contract labor, we're looking to kind of reduce our per diem agency layer. Levels, sorry. We are also doing a lot of hiring events. And that is a really nice way for us to get just word out in general, not just about who we're hiring for, but about our communities. So making sure that we're bringing those potential future associates in. We do a tour, they get to meet people, that they really feel welcome. So even if today is not the day that they come to work for us, they know kind of the quality of building that we are, they know what it would be like. And we find that that creates some word of mouth that is really powerful, even if we don't get that exact person in. So on-site hiring events have been really successful for us.
Great. Great. Thanks, Erin. So I think we might have time for one more question. So I'll throw one more in there and then we can wrap it up. But one of the questions is around, unpredictable demand. So surge demand being a little bit unpredictable. What are some practical ways organizations can prepare for spikes in staffing?
That's a really good question, Liz. And there's a few ways to do it. So one of the things that we do is we actually have some models that predict our likely census based on seasonal trends. And there is some seasonality in our work. And so even knowing that, and again, in senior living, I don't know that we have always adopted some of the great practices that I've seen on the acute care side. But a good example of this is it's very common in pediatric hospitals that you hire 50% more staff to get you through RSV season.
Right.
Because you're going to be full. Well, we sort of have a very similar seasonality in our skilled nursing. And so even thinking about how do you adjust that core staffing model for the times that you can predict are going to have a higher staffing need. And then the other thing that I am going to be testing is really how do we leverage on call in senior living? Particularly, I think there's an opportunity to leverage on call to drive ability to do extra admissions and extra admissions later in the day, which is something that our partners on the acute side are really looking for us to do. It's not super expensive to pay someone on call, but if you can get someone in the door, get them admitted, it's probably worth paying for a couple hours of on-call pay to get that admit done.
Right. That makes sense. Well, thank you so much, Erin. I think that's it for questions, but I just wanted to say thank you for all your insights. I mean, I learned a lot in this conversation and especially in the post-acute space and all of your different ways to think about short-term shifts and, this, what do we call them? Unit-based shifts and keeping your workforce happy and retention and acquisition and just lots of nuggets. So thank you so much. And Lucas, I'll turn it back over to you. Yeah, of course.
Yeah.
Thanks.
And thank you, Beckers, for having me. I appreciate it.
Well, Erin and Liz, thank you so much for being here and taking some time. What a fantastic conversation today. To all of our audience members, thank you so much for the great questions. For those that we didn't get to, we'll certainly follow up with your questions after the session here. And again, Erin and Liz, thanks for being here. And I also want to thank Amen Healthcare for bringing us together, for sponsoring today's webinar. And I hope you all have a wonderful rest of your day.